Thank you, ladies and gentlemen. It's my task now to review a little bit the current concepts, the new anticoagulants, and look for the gap of the LA occluder in the time of the new anticoagulants. I want to touch three topics, still just talk quickly about vitamin K antagonism, the new anticoagulants, and then discuss a little bit what speaks for mechanical versus the pharmacological stroke prevention, atrial fibrillation. The good old warfarin has its history. You see the inventor, Carl Link, who presents it, and it was introduced as a premium rat and mouse killer. And it turned out to be, well, a very important drug in cardiology. And I think we all can say it is one of the most successful drugs we have ever seen. And it was investigated in a large list of trials and has been proven to reduce the risk of stroke about 70 to 80% as compared to placebo or as compared to low dose. So dosing is very important. It has its downsides. You all know it has a small range of safety and efficacy, and we all are concerned about the possible side effects, especially of intracranial bleeding, which is a disaster in a younger patient which is under our treatment and experience such a bleeding. This all, I think, leads to a significant problem that the compliance to the drug is limited. When you start with indication, clear indications, high CHETS-VASc or CHETS scores, you see after 3 years in general practice, we lose about 50%, irrespective how important the treatment is for different reasons. So I think this is a very important task to put as many patients as possible on the required drug. This is the current status. We have now 3 new players in the field. We have 2 anti-factor Xa inhibitors, 1 thrombin inhibitor. They differ in oral bioavailability. They have an important difference in their daily intake. Pradaxa has a twice daily intake, and rivaroxaban for stroke prevention has a single intake per day. They have short half-lives, and for clinical routine it's of importance we have no routine monitoring we have to perform. This is a significant point here. Renal clearance is in 80% for dabigatran, 66% for rivaroxaban, and still 25% for apixaban. Again, we have drugs who have interaction potentials. Those 2 are CYP3A4 inhibitors and have their interaction potential, we know especially from tronidazole from the last time. And this is a protein GP inhibitor with a special list of possible interactions. We have, I think, a really very comfortable situation with these drugs. We have more than 50,000 patients in controlled, well-designed prospective trials. So I think a huge amount of data. And what is very important to compare the drugs, they have chosen the same primary efficacy endpoints, stroke and systemic embolism. So we have a nice option to compare outcomes and effects through the studies. Major bleeding was the principal safety endpoint in all. They have very similar definitions of major bleeding and slight deviations, but also in this part, the safety aspects, we can nicely compare the trial data. You have already seen this slide. Let me briefly summarize the main efficacy outcome. We have the apixaban trial with a significant superiority in the superiority analysis, hazard ratio of 0.79. We have a difficult situation with rivaroxaban from the statistical point, as you know, on the intention to treat. It is non-inferior, but it has not proven superiority. It has some specific reasons in the transition time at the end of the study from withdrawing the drug to start the standard concept. There happened a few events, and that led to the point that as treated, on treatment, rivaroxaban has proven superiority, and you all know the RELY trials with a superior effect of the high dose and a non-inferior effect with the 2 times 110 milligrams. And let me point out one aspect. All drugs were close to that point, but this is, I think it's a good feeling when analyzing all-cause mortality. Apixaban succeeded in demonstrating a significant reduction of all-cause mortality. It's the only trial which made it at that point. The others were sharp or close, but couldn't show statistical significance. For the clinical use, you have already seen the bleeding reduction from John. I think for the clinical use, this point is a very important aspect, that we have the feeling when we use these new drugs, we have reduction in intracranial bleeding. Here are the results for the hemorrhagic insults. We yesterday nicely discussed in the pre-review that this bleeding, this hemorrhagic transformation has a worse or bad outcome, bad prognosis. And we have a more than 70% reduction of hemorrhagic insults using dabigatran as compared to warfarin. And even more important, those patients who have a history of stroke or TIA, they are at a significant higher risk for intracranial bleeding. In this specific cohort, we have only a few events in the RELY trial, but going down from 18 patients to 5 or 2. So I think we have good data that we have a significant reduction in this worst side effect. This is recent data published in April, looking into this aspect of intracranial bleeding in RELY. There are 154 events. I just want to show you one analysis. It is the subgroup analysis to check for independent predictors of intracranial bleeding. And if we look to all patients, you see, for instance, that age has a significant but slight increase of the risk. Prior stroke and TIA nearly doubles the risk of intracranial bleeding, but assigned to warfarin, as determined by the study protocol, goes to a threefold risk increase for intracranial bleeding, and aspirin use is in addition a significant independent predictor. For all the trials and for the clinical use, I think this is of importance. All the new anticoagulants show a significant reduction. Here are the hazard ratios for intracranial bleeding. The winner in this area is dabigatran in both dosages, and apixaban with risk reduction more than 50 to 60% for intracranial bleeding. Let me briefly now touch the downsides or the weak parts of the new anticoagulants, because we are discussing left atrial appendage occlusion. Where is the gap? Where's the role when we look to this strong data of the new drugs? And I think bleeding is an attachment for the concept of anticoagulation, and you can reduce it, but it will be part of this concept. And just take a look into the major bleeding events of the RELY trial. We have for warfarin 3.36%, and when we take the recommended dosage of 2 times 150 milligrams, we are very close. So I think bleeding belongs to this concept, and we will fight with it. When we take a specific look to gastrointestinal bleeding, I think that's an important message for the clinical practice. You know about this big debate that there was a significant increase using dabigatran with respect to gastrointestinal bleeding, 1.51% per year, and this is the warfarin group. But also rivaroxaban has a significant increase in gastrointestinal bleeding. So I think we still will see patients who have bleeding events, and I think this is one of the groups we will think about left atrial appendage occlusion. We have risk for accumulation, we have elderly patients, renal insufficiency, and we have the interaction potential of the truck. You can go to the internet, this is just published, you find more and more reports and data about bleeding events in elderly patients. This is an 85-year-old man with renal insufficiency under full dose of dabigatran. So I think this will be an aspect. This was a red hand letter in Germany last year to tell us that we have to check renal function, so we don't have to measure INR, but we have to measure creatinine for future, though we have to take this into account. And this is a significant limitation in the elderly patient. We have our interaction potential. As you know, for instance, it's not recommended with dronedarone. We have an amiodarone interaction potential with an increment of the drug efficacy of dabigatran of more than 60% as reported. So still there is interaction potential. Verapamil needs the lower dosage and has a significant interaction potential. The need for additional antiplatelet therapy is something which limits the use of the drug. We know from the RELY trial, there was a very nice sub-analysis. When we use aspirin plus clopidogrel in our stent patients, we have a significant increase in the major bleeding events. The relative increase of major bleeding by triple therapy is between 50 to 80%. So those who need additional antiplatelet therapy on a long term, plus aspirin, plus clopidogrel, I think there we have a significant limitation in the use of the drug. And finally, we have the issue with the patients compliant with daily drug intake. There are patients who forget their second tablet, who have minor forms of dementia. So I think this will turn out in the clinical practice. Let me finish with an individual approach and a short case. I think for the clinical practice, we have the risk for bleeding and we have the risk for stroke, which is determined by the trend for thrombus formation in the left atrial appendage. We can get an estimation of the risk for bleeding by the Hasblad score, the history of major bleeding, the age compliant, and the need for additional antiplatelet therapy, which is an important driver for bleeding. And we can use the scores, I think the AF burden, and we can use echo parameters to estimate the risk for thrombus formation in the left atrial appendage. And when we put it together, I think the place for the LAA occluder is the area for high risk of thrombus formation and a high risk for bleeding. There is a clear role for anticoagulation without competition in this low to intermediate risk for bleeding and our medium risk for thrombus formation. When we have a high risk for bleeding, but a low to intermediate risk for stroke, I think monitoring might play a role for patient LA occluder or low dose dabigatran, and I think this can be decided on an individual basis. And when we have the high risk for thrombus formation but low to intermediate risk for bleeding, I think this is the role for the high dose dabigatran or maybe apixaban in future because efficacy counts. A quick case to finish from our practice, which I think is a nice example for choosing the left atrial appendage occlusion. We had an 82-year female patient, persistent AF. She has hypertension, diabetes, and renal insufficiency. She had a TIA a few months ago, since then fenprocumone, and it was terminated by the general practitioner because she has bleeding cystitis, and she showed cholestatic hepatopathy, so he terminated vitamin K antagonism and asked for a new approach. We debated several things. As clopidogrel, a new anticoagulant, it was the time where dabigatran was in the media with bleeding and renal insufficiency, so she didn't want to be put in her situation on dabigatran, and we decided to go ahead for left atrial appendage occlusion. This was the left atrial appendage baseline. We decided to go for a 3 months dabigatran round for bridging, and after that 3 months, we performed implantation. We used the 3D just for your eyes, some nice images, and used the cardiac plug for implantation in 3D technology. Thank you for your attention.